All right, so I will share my screen. All right, so welcome to PNR 134 HESI review. Um, so I'm just gonna strategize our strategies for prioritizing care. Always ask, if I do nothing, what's going to happen? Or, if there's one thing that I can do before I leave that residence room, what can I do? Your ABCs, your Maslow's hierarchy of needs, and then always your potential problem, or is it an actual problem? Are they stable? Are they unstable? Is it acute? Is it chronic? Is it an expected finding or is it an unexpected finding? Remember your nursing process, right? Data collection is always first, planning, implementation, then your evaluation. So these are the clinical judgment measurement modules or model. These are topics that you also will see on NCLEX. So you have your recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. So when we look at how to address the questions, use your nursing process. So the NCLEX is assess, diagnose, plan, implement, evaluate. Your next gen is recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. So we'll start with basic care and comfort. Um, so when we look at some of the sensory changes that occur with our older adults, taking care of those patients with vision and hearing changes. So some of the big things that we want to do, of course, is to reduce the risk of injuries, right? Maybe it's night lights, it's removing clutter and those throw rugs, right? Even sometimes furniture can be in the way. Also want to address communication barriers, and there's a variety of different tools that we can use to address communication barriers. Your presbycusis is the age-related hearing loss that occurs just as we get older. So we know that hearing and vision changes can increase the risk for injury in our older adults. So how do we, what are some things that we can do to help our older adults? Mobility needs, providing for mobility needs to help patients stay active, right? So this could be walkers, it could even be wheelchairs. But of course, we want them to maintain their activity as much as possible. Um, if they are immobile, complications are always a concern. Pressure injuries, for one, doesn't matter if they're sitting in a wheelchair or they're laying in bed. They are at risk for pressure injuries. So making sure that we're offloading those. Oh my gosh, sorry, the words just left me, those pressure points, right? So think of the head, the elbows, the shoulders, the hips, the butt, the heels, the Achilles tendon, the ankles, right? Making sure that we're turning and repositioning, even if they're sitting in a wheelchair, right? We don't want just them sitting in one position the whole day in that wheelchair, still want to adjust their weight. Contractures, range of motion, extremely important um, in preventing contractures, right? We want to maintain their mobility as much as possible. So the last person that just logged in is Zoom user. Can you go ahead and add your name to your profile so you can get credit for attendance? Muscle atrophy, right? The muscles are going to weaken, especially if they're not using them. So again, that range of motion is going to be really important. So I'm going to ask you guys a question. So what are some of the respiratory complications that can occur from someone that is immobile? Anybody?
Shortness of breath.
I'm sorry.
Shortness of breath.
Okay, so how would shortness of breath occur because of somebody being immobile?
Maybe because um they're not well seated.
The well, think of things like pneumonia can occur, and those secretions are going to pool. Okay, if they're and then even with decreased cough reflexes, inability to um clear the secretions. Blood clots occur because of blood pooling. If we're not moving around, the blood is going to pool. So think of, again, it's really important that we are providing range of motion, that we're turning and repositioning. Sleep and rest. So when we look at, think of how sleep changes with aging. Um, Generally speaking, the older adult still needs to have adequate amount of sleep. They do tend to go to sleep a little bit earlier, wake up a little bit earlier as well. But that, circadian rhythm, dementia can affect sleep. Some patients with dementia will sleep more, others will sleep less. So when we look at how we can promote sleep in our older adults, right? Making sure that they're toileted, that they're clean and they're dry, that we're providing a nice, quiet environment for them, so that they can slow down, so that they can go to sleep. All right, so question. So we have an older patient reports that she can't fall asleep at night because she lies awake worrying. Which intervention should the nurse recommend first? So one, a prescription medication for anxiety, B, an over-the-counter product like melatonin, C, a nightly glass of wine before bed, or D, a regular bedtime routine to promote relaxation.
D.
B,
D. The last one.
oh, D, okay. So yes, so it is a regular bedtime routine to promote relaxation, right? So non-pharmacological intervention should always come first before we add medications. The prescription drugs for anxiety are a last resort as they can cause the daytime drowsiness and increase the risk of falls and injuries. Over-the-counter products can interact with other medications, and of course, alcohol can help a patient fall asleep, but ultimately will interfere with the sleep cycle. Um, Health promotion and maintenance. This is chapters 4 and 8 in your basic geriatric nursing. Um, So look at identifying risk factors for disease, heart disease, COPD, and diabetes. Look at your routine screening exams and immunizations. So you should get their yearly flu vaccine, their pneumonia vaccine, as well as their shingles. Um, your screening recommendations are in table 8.1. The presentation of illness is table 8.2, and measuring vital signs is on page 155. So we look at activity and exercise. Of course, we want to make sure that we're choosing those exercises that are age appropriate for patients that have musculoskeletal disorders. So we think of patients that have had a stroke and they have that hemiplegia, which is the paralysis on one side of their body, or the hemiparesis, which is weakness. Always want to use the stronger side. Make sure that we are still trying to build up those muscles, keep them from atrophying. But if they can't use one side of the body, then of course we want to build up that stronger side. Osteoporosis, degenerative joint disease, which could be osteoarthritis or rheumatoid arthritis. Again, Exercise, especially for osteoporosis, weight-bearing exercises are extremely important. And then even offering those mobility tools to help them, whether it's walkers, wheelchairs, sometimes even a cane is effective. Um, but want to build up those muscles so that they are strong to help reduce the risk of falls, reducing the risk of fractures, right? Again, just fall prevention is one of the biggest things that we can do in that, as well as building up their muscles. Tube feedings. So we think of NG tube feedings. NG tubes go right down the nose, down into the stomach, and can provide nutrients for some of our clients. If they can't swallow, if they've had, some other issue, even sometimes with the GI tract, um, it's their way of providing nutrition for our patients that can't eat. Aspiration precautions when we look at patients that are on tube feedings, whether it's an NG tube feeding or even a G tube feeding, always make sure that the head of bed is elevated. We always want to make sure that we're checking placement as well to make sure that it has not moved. Um, and of course, the accurate flow rate. So usually with tube feedings, it is going to be a combination of the dietitian as well as the provider. They are going to look at the recommended daily calories and nutrients that the client is going to need. That is going to determine which formula we choose, as well as the rate that we are going to provide that formula feeding. With ostomies, we have three types of ostomies. We have colostomies, we have ileostomies, and we have urostomies. Okay, colostomy is going to be done in a colon. Ileostomy is a little bit higher. A urostomy is for urinary drainage. So we're always going, if we have a new patient that has a new ostomy, we're always going to provide education on cleaning, how to change the dressing, put the colostomy bags on, as well as monitoring for signs and symptoms of infection, as well as the ostomy itself. We do want that ostomy to be moist and pink. If it starts turning purple, black, other colors, right? That is a sign for concern, meaning it's not getting enough blood flow. With diet and fluid, changes in diet may be required to prevent blockage and promote nutrient absorption. So depending on the area where the ostomy is going to determine the texture of the stool. Generally speaking, the higher the ostomy, the more liquid the stool is going to be. So patients need to be aware of that. And if it's higher, they may want to try some more bulk forming foods. If it's lower, it's going to be more formed stool. So again, they want to make sure they're still getting enough fiber to prevent any blockages. Pouches, so colostomy pouches go right over the stoma site. There's a variety of different pouches that can be used. Some are all-in-one system that come with the wafer and the bag attached. Others have like a separate wafer and a separate bag so that the wafer can stay in place. And then the bag can be changed as needed. And there's also like little charcoal filters, charcoal tabs that can be put into the colostomy bag to prevent odors. Gas is going to still be common, just like anybody with foods that we eat, we generate gas. We can just, teach them how to burp the bag. There's also other products like skin prep and colostomy paste that will help to keep the adhesive on the skin so that you can, so they don't have to change the colostomy bag or the wafer as often just because that can be very irritating to the skin. There's powders and other things that we can use in that as well. Most bags can be emptied, not necessarily having to change them every time they have a bowel movement. That too will help to prevent irritation to the skin around the area. We look at post-operative care, right? Um, Stabilizing the clients and maintaining that stability. Of course, we're going to look at ABCs. Um, Depending on the type of surgery, it's going to determine whether or not, how fast that we can get them out of bed, up and moving. If they're going to be in bed for a while, if they've had a major surgery, like an open heart surgery or something along those lines, where we may not get them up for a day. Always want to make sure that we are, repositioning them to avoid skin breakdown, encouraging that turn, cough, and deep breathing, as well as their incentive spirometry, to help prevent pneumonias. We're always going to check their peripheral circulation. So you want to make sure that you're checking all their pulses, monitoring urine output and fluid balance. Remember, the elderly are going to be more prone to fluid and electrolyte imbalances as well as dehydration. So we want to be very careful with that. Um, Coming out of surgery, things may not wake up as quickly. So we want to make sure that they're urinating, that they have bowel sounds. Any type of surgical wound is going to require us to monitor for signs of infection and excessive bleeding, and then making sure that they have adequate pain management. And so pain is generally undertreated in the elderly population. So, in order for us to be able to get them up and out of bed and moving as soon as possible, we do need to make sure that they have that pain management. Otherwise, they're going to be less compliant with their care. Coordination of care, working with other members of the healthcare team, and this could be providers, specialists, and therapists. So using the nursing process, right? Again, ADPI, how would you use the nursing process to care for a patient with the following conditions? So for urinary incontinence, right? What are some things that we can do for our clients that are incontinent of urine using the nursing process?
Put them on a schedule like every 2 hours for avoiding.
Okay, so putting them on a voiding schedule, right? Or at least making sure that they are changed at least every 2 hours, right?
Yeah.
Trying to identify, those common times. We don't want urine sitting on the skin for long periods of time. It can cause MASD or excoriation. What are some things that we can do for clients with orthostatic hypotension? What is orthostatic hypotension?
Basically, just have them say they're laying down and have them sit for a few seconds before
Like,
they,
mm,
I guess, when the blood pressure drop down real quickly.
when they get up too fast and they experience dizziness.
Right. So it's a drop in blood pressure, right? When they change positions too quickly. So things that we can do, right? Getting them up out of bed, sit them up, have them dangle their feet over the side of the bed for a few minutes until their blood pressure stabilizes. Same thing when standing, right? We don't want to jump them up, have them stand, stand for a few minutes before they start moving around. Presbycusis is the normal hearing loss that occurs with aging. And there's a variety of things that we can do. Obviously, we don't want to yell at our clients, right? A lot of people, as they develop hearing loss, learn to read lips. So we want to make sure that we are standing in front of them, that there's light on our face, that we're not chewing gum, we're not overly enunciating our words. We just want to speak normally. If there's a better ear, you want to speak into the ear that is better. So if it's their right ear or their left ear, um, cataract surgery, so discharge and post-op care, avoid pressure on the eyes. So anything that could potentially increase pressure. So bending over, lifting heavy objects, even straining to have bowel movements can increase pressure within the eyes. So we want to try to avoid those as much as possible. Eye patches worn at night over the operative eye, just to protect it while they're sleeping. So they, nothing gets in that eye, rubs up against the eye, or even like, some people like will rub their eye while they're sleeping. So we want to protect that as much as possible. And the eye drops are super important. So they'll have more than one eye drops. They'll usually have either an antibiotic eye drop and a corticosteroid eye drop. They may have some pain eye drops as well, that need to be administered, making sure that if we're doing the eye drops, that we're doing them at the scheduled times. And if they're doing the eye drops, we want to make sure that they have written directions on how, and, of course, the verbal explanation on how to administer and when to administer those eye drops, to prevent any complications. Pharmacological therapies, this is chapter 7, medications in older adults. So we look at factors that increase the risk for medication-related problems. This is box 7.1. And then factors affecting your drug response in your older adults. Both of these, when we look at it, factors that increase the risk for medication-related problems can be physiological. They could even be, manual dexterity. So make sure you look through those boxes. Common drug categories with precautions related to aging. Your cardiac meds, your diuretics, your opiates, your antihypertensives, anxiety and sleep meds, your antibiotics and NSAIDs. Those are in your Williams book, page or table 7.5. All right. So fill in the blank how aging affects drug response. So absorption, what are some age-related changes related to absorption? Or distribution, metabolism, excretion, any of those?
You say absorption is the rate of absorption may be altered.
Okay, absolutely. So the rate of absorption can be altered. Um, so when we look at it, so oral meds, right? Most of our medications that we give to older adults are going to be taken orally. And so they have to pass through the liver first. Remember, that's that first drug, that first pass effect. Um, that reduces the drug concentration, but generally speaking, in our older adults, right, liver function tends to be decreased, so does blood flow. So there's a reduced first pass effect in our older adults, which can lead to an increase in the available medications. Um, and so other things too, we look at the hydrochloric acid in the stomach. It is less acidic, which causes irregularity in the absorption of drugs. They also tend to have decreased peristalsis, which allows the enteric drugs. It tends to extend their contact with the gastric juices, so the drugs break down quickly. The decreased gastric motility, the slower emptying of the stomach, of the intestine, also slows the onset of the drug's effect. So lots of things that can happen with absorption. When we look at distribution, we have a decrease in our total body mass, lean body mass, total body water content. There's generally an increase in total body fat, which can significantly alter the distribution of our medications. With metabolism, again, the liver is the primary source of drug metabolism. So as a result of aging, generally we'll have decreased liver function, decreased in those metabolic enzymes as well, decreased cardiac output, resulting in reduced blood flow to the liver. That, of course, if the liver is unable to metabolize those drugs, it's going to increase the risk for overdosing and toxicity, and then excretion. Same thing as we get older. We Our kidneys tend to slow down as well. So they are less effective at removing waste products, which includes those byproducts of medications. And so with that too, they're more likely to build up in the system that increases the risk for overdose, as well as toxicity. So again, decreased stomach acid, decreased peristalsis, decreased perfusion. With distribution, the increased body fat results in storage of fat-soluble drugs and tissues, decreased serum albumin, affects binding of drugs. So we look at that. Protein binding of drugs. If the drugs are highly protein bound, and they don't have if they don't have normal albumin levels, that means that there's going to be more drug available to exert its action. Metabolism, again, decreased enzyme activity, as well as, decreased perfusion to the liver, decreased liver capacity, and then excretion, decreased perfusion to the kidneys, decreased filtration rate, as well as the decrease in number of functional nephrons. So polypharmacy, right? That's use of more more medications than clinically indicated. It's a common problem in our older adults. Older adults, use a lot more medications than younger adults do. They may also be using over-the-counter products, vitamins, minerals, supplements, things like that, which is all going to increase the risk for medication interactions. So we want to monitor the use of these really highly or high risk medications. So sedatives, anti-anxiety medications, those are your barbiturates, your hypnotics, your anxiolytics. The antipsychotic medications generally are much more dangerous in the older adult. So we are very careful when we're using those. Narcotics as well, they alter mental status, increase the risk for falls. They're also at a higher rate for potentially overdosing on these medications or taking too much, or they have interactions with other over-the-counter medications. And then, of course, our cardiovascular system. So we want to monitor the use of their over-the-counters as well as their herbal medications to try to prevent any interactions. So like, I don't know, some of the common herbals like your black cohosh, your ginkgo, your St. John's wort, ginseng. There's a variety of things that they use that can cause significant interactions with prescription medication. Medications that should not be crushed or chewed. This is also super important, right? There's a lot of medications out there that cannot be, crushed or chewed, like your enteric coated, your long acting or sustained release medications cannot be crushed or chewed. Some of them can be opened and sprinkled on foods, but we have to be really careful with those. Potassium is another one. So if they're on potassium supplements, those are really large pills. They cannot be crushed, but they can be dissolved in water. Trying to think. Another common one is alendronate that we use for osteoporosis. It is one that also cannot be crushed or chewed. So may have to look at alternatives to that if the patient cannot swallow their pills. So the PN is assigned the care of an older client who returns to the unit after surgery for closed angle glaucoma. Which intervention in the plan of care should the PN bring to the attention of the charge nurse? So A, assist with ambulating to the commode. B, monitor intake and output Q8 hours. C, administer morphine 4 milligrams IM Q 2 hours PRN pain. Or D, place an eye patch on the operative eye during sleep. So which intervention in the plan of care should we bring to the attention of the charge nurse?
C.
C.
So C, administer morphine. So I will tell you, glaucoma surgery, generally they aren't going to get morphine. But if you don't remember glaucoma, okay, what if I don't know anything about postoperative care for the surgery? How could I answer the question? So eliminate standard interventions and then identify risk. What can most or what could cause the most harm to the patient? So morphine can increase intraocular pressure and is contraindicated for patients with glaucoma. So again, they've had eye surgery. We don't want anything that's going to further increase intraocular pressure. Assisting with ambulating, right? Go to the restroom, monitor eye and nose, placing an eye patch on the operative eye during sleep would all be appropriate interventions. Physiological adaptation. So identify and provide care for clients with fluid and electrolyte imbalances. Again, we know that the elderly are higher risk for dehydration for a variety of reasons. Decreased mobility may cause them to, maybe harder for them to get up and go to the restroom, right? So they may not drink as much. They may not have, so that they don't have to get up and use the bathroom as much as possible, so they will avoid drinking, basically just drinking the minimal amount. Um, so when we look at the signs and symptoms of dehydration in our elderly population, dry or sticky mouth, and I'm sure everybody has been a little bit dehydrated at some point in their life. And so, even when you're extremely thirsty, think about how your mouth feels. They may be lethargic, their eyes may be sunken in, obviously weight loss. Um, Little or no urine output. So remember, 30 mLs per hour is the minimal urine output that we should all have. If they aren't producing at least that, then we know that they potentially are dehydrated. Their urine is dark and yellow, or skin turgor, delayed capillary refill. Dizziness, confusion or changes in mental status, lack of tears, lack of sweat, falls, difficulty walking, low blood pressure, rapid heart rate, abnormal labs and electrolytes. So we, make let me not skip. Making sure that they have, fluids available and that we're offering them fluids. So hypervolemia versus hypovolemia. So we kind of talked about a little bit about the fluid volume deficit. Restlessness, anxiety also may be a symptom of hypovolemia, as is, cool, clammy skin, decreased cardiac output, unconsciousness, hypotension, weak or absent peripheral pulses can occur when we get to more severe fluid losses. With hypervolemia, they could develop tachypnea, shortness of breath, crackles, difficulty breathing. Pulses will be more bounding. Hypertension is common unless they're in heart failure. They may have distended neck and hand veins, acute weight gain, edema. That pulmonary edema is what's going to cause the shortness of breath, the crackles, and the orthopnea. Orthopnea is difficulty breathing when supine. Generally with orthopnea, they breathe much better when they're in, a sitting up position. So the nurse suspects that an older patient is dehydrated, which assessment finding is most reliable. So most reliable in a client that is dehydrated. So poor skin turgor on the back of the hand, dry pale lips, elevated urine specific gravity, or sunken eyes. Which of those would be most reliable indication that patient is dehydrated?
B.
So it would be the elevated urine specific gravity. So most reliable, right? And so getting a urine sample and looking at that specific gravity is going to give us the indication of what's going on. So elevated urine specific gravity is a sign of highly concentrated urine. It is the most accurate measurable sign of dehydration. Skin turgor in the back of an old person's hand can be loose due to natural loss of elasticity in the skin. Dry mouth can be a sign of dehydration, but could also be caused by medication use, disease, or natural changes of aging. Sunken eyes could also be related to poor sleep, genetics, or age-related loss of elasticity in the facial tissues. So again, always look for those key words like most, um, the best, that kind of thing. So IV fluid replacement, we assess the needs for IV fluids. So dysphagia, or difficulty swallowing, forced dehydration, delirium. With the elderly population, there is a huge risk, even if we have a client that's dehydrated, and we give them fluids, they still, they will, and it does increase the risk for fluid overload. Um, veins, veins in the elderly, they can infiltrate rather quickly. And then if you add into the fact that they may have dementia, Alzheimer's, things like that, they may pull and push at that IV site, which can cause that IV to infiltrate as well, or even in certain positions. Placement of the IV is super important as well. Monitoring those IV sites is really important. Looking for signs of infiltration, so we don't cause any issues. When we look at perfusion and aging, so perfusion is the blood flow through the capillaries and the tissues. It decreases with age as the heart muscle weakens and blood vessels lose elasticity. So risks of ineffective perfusion. So if we're not getting enough blood to our tissues, right, there's decreased oxygen delivery to the heart muscle itself. With that coronary circulation, the decreased GI absorption of nutrients and medications, decreased metabolism of medications by the liver, right? We're not getting adequate blood flow. Decreased excretion of toxins and other medications by the kidneys, decreased blood flow to the tissues of the extremities, which then also increases the risk for pressure areas. So if we don't have good blood flow to those areas, all of those things can happen. So Mr. Williams is a retired 78-year-old. He has been a smoker for 42 years. He has a diagnosis of chronic hypertension and high cholesterol. He injured his back fixing his car last year and hasn't been very active since then. Today he comes to the clinic with complaints of left lower leg pain, especially when walking. On assessment, his left lower leg appears thinner than the right. The skin is flaky and dry. His right foot has a bluish color and is cold to the touch with a weak pedal pulse. So, what do we recognize here with Mr. Williams? What are some of the things that draw your attention?
The color,
Color, absolutely. The color of his skin. What else?
it's cold to touch,
It's cold to the touch. Mm-hmm.
and he has a weak pulse.
And he has a weak pulse. Very good. Um, What cue matters most? What do you think of out of all of those, what do you think matters the most?
The weak pulse?
Okay. So what could, sorry, what could be causing the symptoms? What do you think is causing those, what do you think is causing those symptoms?
Um, Lack of blood flow to the legs or to the feet.
Okay, very good. So lack of blood flow to the feet. So that also would probably be our priority as well, right? So Mr. Williams most likely has peripheral artery disease, um, which kind of goes with those symptoms that he was experiencing, right? So, um, where is it? So he's got complaints of left lower leg pain, especially when walking, and then of course the assessment, it's thinner. The skin is flaky and dry. His right foot has a bluish color. It's cool to the touch with a weak pedal pulse, right? So that brings us to peripheral artery disease. This is what a normal artery looks like, okay? And this is what peripheral artery disease would look like. So we have atherosclerosis, all right, which is a hardening of those arteries. If they have elevated triglycerides, they also may have some plaque that builds up in those arteries, which is going to decrease blood flow to those extremities. So the signs and symptoms are what we call it intermittent claudication. So basically, they're going to have cramping when they're up and walking because as they're walking and the muscles are contracting, it's actually decreasing blood flow to those extremities. So generally, with intermittent claudication, the pain is relieved with rest. Skin is cool to the touch and shiny. They also will have muscle atrophy and weakness again because we're not getting enough blood flow to those tissues. So we can do an arterial brachial index. We can do ultrasounds. We can do angiographies. Um, and then some of the solutions, if they smoke, we want them to quit smoking. We want to put them on an exercise program. And if any of these arteries are, really blocked, then of course we can do surgery to unblock those arteries, put stents in, filters. The goal is, or the outcome is, of course, to improve circulation, mobility, as well as functionality. Type 2 diabetes. Um, Body cannot process glucose. So with type 2 diabetes, we either have a decrease in we either have a decrease in our insulin production or we have increased resistance to of the cells to the insulin that is producing. So we'll do a lab. Hemoglobin A1C is it's an awesome lab. It gives us an average of their glucose levels over the previous 3 months. We can also do fasting glucose levels or routine glucose levels, depending on the situation. Um, with type 2 diabetes, we first first course of action is always going to be diet and exercises. Those dietary changes are necessary for glucose management. And we will use oral medications versus injectable medications. So metformin is one of the most is the most prescribed first choice medications, first line drug for type 2 diabetes. Glipizide is another. There's a variety of other medications out there. There's a ton of anti-diabetic medications. But those lifestyle changes, right? Dietary modifications, really big to make sure that we are managing those carbohydrates. Weight management, especially if they're overweight, even losing as little as 10% of their body weight can cause a significant or have significant positive effects on glucose management, portion control, increasing vegetables, proteins, fruits, again, decreasing those carbohydrate intake. Monitoring skin, wound checks, feet, moisturize, burn prevention. Diabetics really need to inspect their feet daily. Any minor cuts in a diabetic patient can lead to devastating wounds, leading to amputation. So we really want them to monitor their skin. They need to see a podiatrist, right? Or uh, even just to cut their toenails. Um, Burn prevention, decrease in sensation, increases their risk for injury. Um, and then, of course, smoking cessation is extremely important. Thyroid disorders, hypothyroidism. So I always think of these like Eeyore and Tigger. So hypothyroid would be Eeyore, very sluggish metabolism. Generally, you're going to be a little bit more overweight. Slow heart rate, dry skin, hair loss. They are sensitive to the cold, so they're always cold. And we use levothyroxine is the most common medication that we use for thyroid replacement. But you can see, here they'll have the puffy face. They could have a goiter, which is an enlarged thyroid, slow heartbeat, weight gain, constipation, infertility, again, more slow and sluggish. On the other hand of that, we have hyperthyroidism. They tend to be thinner, have the rapid heartbeat, weight loss, diarrhea, bulging eyes. Like I said, I think of this as Eeyore and Tigger. They're going to have a little bit more energy. They are going to have heat intolerance, so they're going to always be hot. They also too can have a goiter, so the goiter can occur in either hypo or hyperthyroidism. So with hypothyroid, if we don't have enough thyroids, hormones circulating around, then the thyroid is going to be continuously stimulated to produce the thyroid hormones. And even if they're not producing the thyroid hormones, the overstimulation is going to cause it to grow. Same thing, or not the same thing, but with the goiter and the hyperthyroidism, the thyroid is overacting, right? So more it moves, the more it works, it's going to get large. It can get larger. Um, Cognitive impairment in aging, delirium versus dementia. Recognizing the factors related to mental status that contribute to injury and assessing signs and symptoms of infection in the elderly. Delirium is a rapid onset. It occurs anywhere between hours and days. They'll have a reduced level of consciousness. Um, they could have increased or decreased psychomotor activity, disturbed sleep and wake patterns. Disorientation is common with perceptual disturbances. They also can have visual and auditory hallucinations, memory impairment, decreased attention span with disorganized thinking. But generally speaking, delirium is reversible if we identify the underlying cause and we treat that. It can recur with acute illnesses. Think of, even sensory overload in the hospital or too much sensory input can lead to delirium. With dementia, it has a slower onset, anywhere from months to years. They don't have any changes on their level of consciousness initially. They are pretty stable, but they have that impaired memory, right? Loss of abstract thinking, judgment, language skills, motor skills, ability to recognize familiar people or objects. Um, and dementia is not reversible, right? It's going to be a progressive disorder or disease. Alzheimer's disease is the most common cause of dementia in the United States. The brain cells are affected by atrophy and what we call beta amyloid plaques. Medications can be prescribed, so there's a variety of different Alzheimer's medications out there. However, They are not a cure. They're there just to assist and help with the symptoms. There's 3 stages. So if you go to page 190, you'll see the 3 stages. It's box 10.5 in your book, sorry. The preclinical stage, they don't have any signs and symptoms. Um, the mild cognitive impairment, they'll have some mild changes in reasoning and memory and vision. So like, where did I put my car keys? Um, and then in with dementia that is caused by Alzheimer's disease, they have memory impairment, behavioral symptoms, impaired functional ability, and it is the most common form of dementia. So dementia medications, um, cholinesterase inhibitors. So your cholinesterase inhibitors break down or block the breakdown of the neurotransmitter acetylcholine, which affects mood and memory. And so if we block the cholinesterase, then we don't have the breakdown of acetylcholine. So that means that there's more available for the body to use. Again, they help to improve the cognitive and the behavioral symptoms. They are not a cure. They are not going to reverse anything. Again, they're just to help with the symptoms. So we have donepezil and rivastigmine. We also have memantine. Memantine can help to reduce abnormal brain activity. The choice of medication is dependent on the patient, could be patient and provider preferences, or based off of what the symptoms the patient is experiencing. Parkinson's disease. Parkinson's disease is a progressive degenerative disorder of the central nervous system. So the key or what is the word I'm looking for? The acronym for the key symptoms of Parkinson's is TRAP. So tremors, rigidity, akinesia, and postural instability. So this is kind of what your Parkinson's patients will look like. They'll have the stoop posture, the rigidity, they'll have the flexed elbows, they can have tremors, um, shuffling, short stepped gait, hand tremors, reduced arm swing, forward tilt of the trunk, and masked face. So basically a blank expression. Drooling is also very common. So again, they also, again, they have that short shuffling gait. So they don't pick their feet up when they walk, which increases their risk for falls. They also have, I don't know how to explain it, and they have like difficulty getting movement started. Okay, so if they're walking, they're okay, but if they stop, they may have difficulty getting started again. So they do this rocking motion, right, to kind of get the momentum to go forward, which then also increases their risk for falls. Um, it also affects the cognition. So dementia is very common in our Parkinson's patients. So impaired memory, confusion, anxiety and depression. Um, and so we look at treatment for Parkinson's. With Parkinson's disease, we have an imbalance of acetylcholine and dopamine. Okay, so acetylcholine is an excitatory neurotransmitter in the central nervous system, and dopamine is an inhibitory. And so generally in most patients, right, we have a nice balance. Um, with patients that have Parkinson's disease, they have an increase in acetylcholine, which is what leads to those tremors and those other symptoms that you see. So treatment is, oh my gosh, it is not levothyroxine, um, carbidopa, levodopa. I don't know why I couldn't remember that. That is to help increase the levels of dopamine in the body. Physical therapy, occupational therapy are also really important. Physical therapy for muscle strengthening, and then occupational therapy to help with those ADLs. So the nurse is caring for a 75-year-old patient with Parkinson's disease, what complications of Parkinson's is the client most at risk for? So hypertension, aspiration, falls, diarrhea, or hyperactivity. So which of those is the Parkinson's patient at the most risk for?
Falls.
Falls.
Falls,
Aspiration
aspiration,
and diarrhea.
nope. Just the falls, just the aspiration and the falls. Everything is going to
Oh,
slow
okay,
down, so
okay.
it's going to be more constipation than it is diarrhea. So yeah, so Parkinson's causes the dysphagia, which can lead to aspirations. Fall risk is increased due to tremors and the postural changes. All right. So working with confused adults, this is the story of my life. So behavior management, reinforce education to family caregivers to manage patients with behavioral disorders. Depending, not every patient that has dementia or Alzheimer's is going to have behaviors. Some of them are just, very just I don't know the word for it. They don't have behaviors. But we do want to provide this education for for their family caregivers. So when we're working with clients, when we're working with families and we're providing education, we do want to incorporate behavior management techniques. Um, Diversion, like reminiscence, music therapy. So here are some of the general approaches for working with confused older adults. The biggest thing is, and I promise, providing a calm, safe, structured environment with limited number of stimuli is super important. Lots of noises, TVs, radios, even lots of people talking can be very overstimulating and can lead to some of the behaviors in some of our confused adults. Calm, gentle, one-on-one approach. Speak normally and informally as though the person is not confused. Allow plenty of time. Avoid hurrying. You don't want to like walk into the resident's room or the client's room and be like, "All right, Mr. Jones, time to get up. Let's go eat breakfast," and just, be really quick. They need time not only to process the information, but they need time performing those tasks that we need them to perform. Determine the confused person's reality, avoid confrontation or forced reorientation. Meet them where they are. If they're at a bus stop in New York City, then they're at a bus stop in New York City. That's where we're at. Okay. Reorientation can just increase agitation. So if they're not able to be reoriented, we want to meet them where they are. Encourage reminiscence using family pictures, common activities or objects, provide familiar clothing and personal items from home, redirect attention or use some other form of distraction to reduce anxiety, provide safe repetitive activities within individual capabilities, provide continuity of care with a limited group of caregivers, develop and maintain daily routines, and then avoid sudden changes in routine, room, or caregivers. All right, so reduction of risk potential. So the Fulmer Spices is assesses patients for common geriatric syndromes in order to reduce health risks and identify areas to focus care. So we look at, do they have any issues with sleep, eating, feeding? Are they incontinent? Are they confused? Have they had a fall or they increased risk for falls as well as skin breakdown? The Braden scale that assesses their risk for developing pressure ulcers. It's based on their sensory perception, their activity, their mobility, nutrition, as well as friction and shear. So identifying client factors that contribute to accident or injury prevention. So lots of those in the older adults. Always use your proper body mechanics for transfers as well as lifting. Urinary retention. So some of the signs of urinary retention, some of the causes of urinary retention. So it could be because of neurological, spinal cord injury. In gentlemen and guys, it could be the result of an enlarged prostate. So that prostate wraps, you can see like 3/4 of the way around the urethra. And when it enlarges, it pushes pressure. It can put pressure on the urethra and cause constriction, which prevents them from urinating or can cause issues with urinating. Almost they have some pressure in that area as well because they're not able to release their urine. Um, so insert, remove, and maintain urinary catheter, including expected response, a TURP procedure, which is the transurethral resection of the prostate. They can go up transurethrally, means that they're going to go up the urethra, and they can resect the prostate to alleviate the constriction on the urethra. Um, we have Foley catheters that we can use. We have condom catheters that we can use. Condom catheters are non-invasive, right? It literally just goes over the penis like a catheter would. So allows the urine to drain. We talked about BPH. Um, Precautions after hip replacement surgery. So hip precautions, no adduction of the hips or turning inward. So we don't want to, and we don't want them to lean forward. So if you look like this, right, keep your hips at a 70-degree angle, so with your knees lower than your hips. So you can see that the knees are lower than the hips. You don't want to bend your hips more than 70%. Okay. So you can't sit up straight in a chair at that 90-degree angle or even higher. Don't bend forward. Don't cross your legs at the knees or ankles. Um, don't roll your hips inwards or outwards so you can see the way the feet are. They should use an abduction pillow that will help to keep the legs separate while they are laying on their back or their sides to prevent this from occurring. Um, with our hips now, I mean, after hip replacements, they're up walking almost immediately after surgery. So we're working with that strength, right, to help build up those muscles immediately after surgery, right, help to maintain the bone mass. We're also, by getting them up and moving, right, we're just reducing some of those complications of immobility like your pneumonias, your blood clots, that kind of thing. Oops. Um, Preventing complications, reinforced teaching on methods to prevent complications of common conditions of aging. So diabetes is all about maintaining tight glucose control, making sure that they're following their diet plan, that they're taking their medications as ordered, that they're inspecting their feet. Osteoporosis, again, we want them to have weight-bearing exercises that helps to increase muscle as to help protect the bones. Sleep disturbances, foot drop, male incontinence. Talked a little bit about all of those. Okay, so bow tie practice. So with your bow tie questions, you want to read the chart notes, the vital signs, the lab results, and recognize those cues. You want to choose the most likely complications based on your analysis of the cues, and then identify the actions that would be most evident for your patient, and identify the parameters that you would monitor based on the outcomes that you're looking for. So the nurse is caring for a 92-year-old male on a medical unit waiting long-term care placement. At 04:24, client rang for assistance and nurse found client on the floor beside the bed. The client states he was getting up to use the bathroom, felt like the room was spinning upon standing, became incontinent of urine, slipped on the urine, then slid down the side of the bed. The client presents alert and oriented to person, place, time, and situation, denies hitting head on any portion of the bed or floor, and denies losing consciousness at any time. Denies any pain at present. Pupil is equal and reactive to light at 2 millimeters, moving all four extremities independently with power, with motor power strong. Client was able to assist with standing and denies any pain. Client denies any chest pain, shortness of breath, or palpitations. Client assisted to washroom and cleanse of urine, his linens changed, and client repositioned in bed. The client's past medical history includes hypertension, benign prostatic hyperplasia, dyslipidemia, coronary artery disease with myocardial infarction in 2002. So his temperature is 98. Well, let's see. This is his trends. I'm not going to read all of those to you. So he gets Lasix or furosemide, 20 milligrams twice a day. He gets metoprolol, 50 milligrams twice a day. He gets Ramipril, 2.5 milligrams by mouth once a day. And he gets Lipitor, 40 milligrams by mouth once a day. So complete the diagram by identifying from the choices below to specify what condition the client is most likely experiencing. 2 actions the nurse should take to address that condition, and 2 parameters the nurse must monitor to assess the client's progress. All right, so based on all the information, what 2 actions should we take for this client? All right, I'll just skip this line. So client is most likely experiencing postural hypotension. So we want to give them a urinal, and we also want to discuss with the healthcare provider the dosages and times of the medication, right? He's taking Lasix twice a day, once in the morning, probably once in the evening. And so that's going to increase his need to urinate, especially at night, which increases their risk for injury and falls. Parameters to monitor would be your blood pressure as well as pain. Let's see. Labs, which labs would the nurse monitor, or I'm sorry, why would the nurse monitor the following labs? So electrolyte levels, right? Electrolyte imbalances, delirium, dehydration, especially when they were taking that loop diuretic, right? We know that they are not potassium sparing. So we're going to lose potassium for hemoglobin and hematocrit, anemia, low O2 saturations, dehydration. White blood cell count would indicate if it was high, it would indicate infection. BUN tells us about kidney function and dehydration, glucose levels, diabetes, and then urinalysis will tell us the symptoms of UTI, hyperglycemia, blood or protein in the urine, high specific urine gravity. High urine specific gravity can be a sign of dehydration. So we have an older female arrives for an annual visit to the urologist due to a change of history of changes in serum values related to renal function. What changes should the PN expect in an older client due to normal aging? Hematuria during urinalysis, a decrease in the glomerular filtration rate, chronic bladder infections, or urinary incontinence. Which of those would be expected in an older client that's aging normally?
I say B.
Awesome. Yes, decrease in that GFR, right? So decrease in that GFR, right? That means our renal function is decreasing. Psychosocial integrity, communicating with older adults is going to be chapter 5. And then in your concepts book, it's 11 to 14. So with the aging process, we want to identify client knowledge and reinforce education on the aging process, right? Just kind of give them a general idea of what are some of the things that they can expect as they get older. We also want to compare client to developmental milestones. So this is Erickson's stages, his psychosocial stages, identify risk factors for disease, identify health seeking behaviors, age appropriate screenings. So that's chapters 3 and chapter 4. But therapeutic communication, right? This is something that we should use with all of our clients, whether they're young, whether they're old. And so some of the techniques that we can use, reminiscing is a big one. Also looking at the 5 stages of grief, which can occur for a variety of reasons, whether it's a new diagnosis, whether it's a loss of a blood, of a relative or a family member. It could even, oh, I forgot what I was going to say, potential loss of something that could occur. We always want to make sure that we respect their personal values and beliefs, that we're providing emotional support, grief as well as anxiety, and always ask those open-ended questions. Remember, open-ended questions are going to give us the most information from our clients, rather than those closed-ended questions. Anticipatory grieving is grieving that occurs before a loss, and this can occur for a variety of reasons. So this could be like they know, they got a horrible diagnosis, they know what's coming, and they can start the grieving process. Extended grief or complex grief is grief that extends beyond what we would consider a normal grieving period, which can cause lead to depression, not wanting to perform their ADLs, as well as other issues. Elder abuse and caregiver stress. So caregiver stress, older adults who are frail or cognitively impaired have more complex needs, which increases the risk for abuse. It's about recognizing caregiver burnout when we're working with clients and their families. There's things like respite care, support groups, and other things that could be beneficial to our caregivers. Always know that as nurses, we are mandatory reporters. And so if we suspect abuse, then, we need to try to identify it. All right, so an 80-year-old woman, our 80-year-old patient, sorry, comes to the clinic with her adult son. She tells the nurse, since my son moved in with me to be my caregiver, I never seem to have any money in my account anymore. What should the nurse do first? So one, advise the patient to open a new checking account. B, interview the patient alone and document her statements. C, call the patient's son into the room and confront him about the money. Or D, can contact the appropriate authorities to report suspected financial abuse. So what is the first thing that we need to do in the situation?
D
D, D.
or
Correct.
B.
Yep. We want to interview the patient alone and document her statements, right? So before we report it, right, we need to get all the facts that we can. It's best to question the patient alone so that they can speak freely. If the son was in the room, right, probably wouldn't be able to tell all of the information, he probably won't tell all of the information that is needed, because, then what could happen once they leave, right? Um, all right, so here we have some more questions. All right, so an older male client with Parkinson's disease is discharged home with carbidopa or with levodopa carbidopa or Sinemet, instructions to his wife for care. Which statement made by the wife best indicates that she understands her husband's needs? So A, it is important to keep my husband in a chair or a bed as much as possible to keep him from falling. B, I will notify the provider if my husband has involuntary movements of the extremities. C, since it is difficult for my husband to eat, we should stay in the house instead of going out to dine. Or D, I should expect my husband to be incontinent of bowel and bladder as the disease advances. So regarding Parkinson's disease and the use of medications and instructions, what would indicate that she understands her husband's needs?
Say B.
D.
D.
It is B. I'll
Oh,
notify the provider if my husband has involuntary movements of the extremities.
What does that mean?
So if they has got the patient that's Parkinson's disease going home on medications, all right, the involuntary movements, the tremors. So if they have
Oh,
tremors, they need to notify the provider or
okay.
involuntary movements.
Okay. Thank you.
yes.
Uh-huh. All right. Let's see. All right, an older male client who is a new resident in an assisted living facility is having difficulty going to sleep since his arrival. Which intervention should the PN implement first? A, encourage the client to take a warm bath at night. B, ask the client what has helped him in the past. C, recommend the client not take daytime naps. Or D, offer the client a glass of warm milk before bedtime.
D.
So what?
D.
D as in dog.
I said B as in boy.
Okay. So yes, B as in boy. So A, C, and D are effective interventions, but the first intervention should be to ask what worked for him before he arrived. So the key is he is a new resident. He's in an assisted living facility. It's a new environment. And so we want to look and see what has worked for him in the past and then try to include that into his plan of care. All right, older clients are at highest risk of, older clients are at highest risk of abuse and neglect due to which of the following factors? So this is a select all that apply. So A, needs are greater than the caregiver's abilities. B, client's declining strength. C, fixed income. D, longer life expectancy. Or E, lack of exposure to technology and trends. Which of those increases their risk for abuse?
B.
I say A,
Okay. It's select all that apply. What else?
B, and E.
Okay.
A,
So
B.
A and B. So needs are greater than the caregiver's abilities, client's declining strength. Fixed income is not related to an abuse. Longer life expectancy, and lack of exposure to technology and trends are not related to abuse. All right. The PN is reinforcing discharge instructions with the family of an older client who was recently admitted for an intestinal obstruction. Which statement indicates the family understands the instructions? So we have an intestinal obstruction. So A, increase protein and carbohydrates in daily diet. B, limit activity to bed rest for the first week and increase incrementally each week. C, report abdominal distension, constipation, or nausea and vomiting to the provider. Or D, drink liquids 2 hours after meals instead of during meals. So, what would be an appropriate intervention for a client that has an intestinal obstruction?
C.
C.
C. Your report.
Very good. C. So report abdominal distension, constipation, or nausea and vomiting to the provider. All right, the home health PN is visiting an older client with chronic hypertension. What evaluation is most important for the PN to complete with each visit? Sorry. So we're visiting an older client with chronic hypertension. So A, the ability to ambulate, B, signs of dehydration, C, effectiveness of medication, or D, familial support.
C.
Yes, C.
Very good. Want to evaluate the effectiveness of the medication. All right. An elderly patient is being discharged home on digoxin. Which statements below verbalized by the patient demonstrates they understand how to properly take this medication? Select all that apply. So A, I will limit my intake of foods high in potassium. B, I will not take this medication and notify the physician if my heart rate is less than 70 beats per minute. C, I will measure my pulse rate before every dose I take. And then D, it is important that I immediately report any vision changes I may experience while taking this medication. So which of those is how we should take digoxin?
C,
C.
D, and A.
Say C and D.
Very good. C and D. So with this one, low potassium levels increase the risk for digoxin toxicity. So we want them to make sure that they are including potassium in their diet. So we don't want to limit those. It's less than 60 beats per minute. So if their heart rate is less than 60, that's when we want to report. So yes, correct answers are measure their pulse rate before every dose they take. And then, because again, unless if it's less than 60, we're going to hold it and call the healthcare provider. And then it is important that I immediately report any vision changes I may experience while taking this medication, right? Because vision changes are a sign of dig toxicity. All right. A frail elderly client is admitted to the unit with a diagnosis of pneumonia. Which finding is most important for the PN to report to the provider? So we have a diagnosis of pneumonia. So fever and chills, confusion and dehydration, crackles in the lung field, or nausea and vomiting. Which is most important for us to report to the provider?
C.
B.
So confusion and dehydration are going to be the highest risk, right? So think about it, right? With pneumonia, oops, I didn't mean to do that. With pneumonia, right? Fever and chills, probably expected, right? Because they were just admitted, so they have fever and chills. That's very expected. Confusion and dehydration is something that we would be concerned with. Crackles is also probably, something that we would expect with somebody that has pneumonia. And then nausea and vomiting generally is not going to be related. So that highest risk is going to be with that confusion and dehydration. All right, a frail elderly couple asked the PN if they have to watch their salt intake because food does not taste as good as it used to, so they have to season most foods. What information should the PN offer the couple? So, A, boredom may influence how the taste of food is perceived in different seasons, can stimulate taste. B, with age, an increase in sodium intake is needed to compensate for a decrease in renal function. C, short-term memory loss and confusion may be the reason they want to over-season their food. Or D, taste buds are often dull due to atrophy, so older clients should use other seasons instead of salt.
I think
The
I'll go
last,
with D.
the last one.
Very good. Yes, absolutely. Taste buds are often dull due to atrophy, so we should use other seasons instead of salt, right? We don't want to use salt in high in our excessive amounts of salt, I should say. All right, good job. Does anybody have any questions?
The SATA, SATA that I saw in one of the question, what does it mean?
Select all that apply.
Oh, okay. Thank you.
You're welcome.
All right. Thank you.
You're welcome. You guys have a great night
Thank you, you
and
too.
good
You
luck.
too.
All right.
You
Are we
as
gonna have
well.
this PowerPoint?
Your instructor should have posted it
Okay.
in the course shell.
All right. Thank you.
You're welcome.
Okay, good night.
Good night.